Hello, my name is Dr. KimBlake, and I'd like to talk to you today about gastrointestinal issues in Charge syndrome. And it's really, does your gut talk to you? So how I think we'll go through this today is that I'm hoping that you're going to be more knowledgeable about the GI system at the end of this presentation. Maybe some more questions for me, and that you'll see where my research interests are as well. So we'll start off with mortality and morbidity. There's no doubt that the GI system can be forgotten in Charge when you've got all the cardiac stuff, the breathing stuff, coagulatriasia happening, but it really causes a huge number of hospitalizations, numerous procedures, multiple medications, and really it is a number one on the mortality morbidity side of things. And you can't believe it gets forgotten. There's often not a GI specialist involved in a child's, an individual with Charge syndrome's program. So really looking at all the feeding issues, the gastrointestinal issues from literally from birth to adulthood, even the adult issues such as the pocketing and the overstuffing that can result in choking and aspiration, down to things like abdominal adhesions and gut obstruction that can happen. Rare, but it can happen. So that's our thoughts about the sort of mortality, morbidity. The gut's a huge organ. It's the biggest organ from nose, from mouth, nose, smell, right the way down to your anus. So it's sort of mouth to anus organ wise. It's a hidden organ in many respects, but now we know more about the vagus nerve, and I'll be talking more about that. It really is an organ system that needs more research and more attention paid to it. So with the anatomy side of things, you have a huge amount of facial issues going on. You've got the structural facial issues. That's the actual structure of the face that we know is different in Charge syndrome. It gives the Charge facial features. It gives what people look and say, oh, you know, that person looks like they have Charge syndrome. So you've got what we call the maxillary facial. So you've got the anatomy, which is different. The biggest part of it being different is you've often got crowding around the tonsillar area, the adenoids. They may not be very big or hypertrophied, but because of the actual anatomy, that can cause problems with breathing, problems with swallowing, problems with just the upper airway itself. You've got a smaller oral cavity, which can be crowded, especially when the teeth start to come in. You've got problems with drooling, not swallowing. Again, the nerve impulses, your cranial nerves not working, so the swallowing mechanism is not working. And you've got increased saliva that's filling up that oral cavity that's already small. So it gives you that picture of why things don't happen well at even the top end. As before we even start thinking about the bottom end. There has been some thoughts about what's called the hypoglossal nerve stimulator to help with Down syndrome and the breathing. I think those ideas are good that they're there. We may be thinking about more vagal nerve stimulator or glossopharyngeal nerve. I mean, there are other cranial nerves that I think are probably more affected in Charge. But the anatomy and what's happening is a good place to start, and certainly a good place to think about all the issues, which include your airway issues, your gut issues, or your swallowing issues, and it's sort of everything comes together with that anatomy. Salivation. We think of the salivation in Charge syndrome not being too much about excessive production, but probably more the unable to swallow or deal with saliva. We don't think about swallowing. We swallow all the time. It's an autonomic system that helps us do that swallowing. When we do think about it, we do. So, I'm going to have a drop of water. And I'm going to think about swallowing that. I mean, if I had a carrot there, I think about chewing it and swallowing it as well. But when it comes to general things like saliva, you don't think about that. That sort of happens naturally. But in charge syndrome, we know that system is not working properly. Airways can get obstructed. I had a little baby looked after with charge syndrome on the intensive care unit. They couldn't get the trach out, and what they did do, I got my ENT surgeon up to come and have a look. We had never done it before at this hospital. They had done it in Montreal. There was a good paper that was setting the precedent for that, and we Botoxed the salivary gland. So we Botoxed the parotid gland, which you can sort of feel there around the parotid area. We ultrasounded and Botoxed the submandibular gland, and by Botoxing those, it reduced the amount of saliva. We did use a drug called glycopyrrolate as well, and with that combination, we were able to extubate little Freddie, and then Freddie ended up with having regular Botox injections. I think it was every four months to keep the saliva down. And Mum would actually say he's starting to choke a bit, he's having problems, and we'll be doing that regularly. And we've been doing more Botoxing regularly with our charged patients. It doesn't always work. I've had many families that say to me, we've tried it, it doesn't work. Sometimes you need it in combination, sometimes it just isn't enough and doesn't work. The aspiration and tube feeding is a problem. Going from a nasogastric tube to a button or a G tube, J tube is always a great angst for lots of parents. I think people have sort of got over that now a little bit more and said, you know, we can still G-tube feed, but we're looking at getting that G-tube out at some point, or that tube out at some point. Nutrition being such an important part of a baby's life, and making that safe is really a talk in itself. And I rely a lot on my speech language pathologists, ENT people, feeding team, OT, to look at the whole feeding spectrum for charge. What I am concerned about is aspiration and problems with aspiration, and we find that can happen very much so after procedures, after operations, after anesthesia. So again, practically every talk I do, I put in a plug for having multiple procedures done under one anesthetic. No more risk in harm from that. Actually, you are preventing harm by having less anesthesias. So something I've been very interested in, and again, we've got some published data on that, is the what we call the packing and the overstuffing of the mouth. It's sort of where you get the chipmunk, where the mouth is sort of full of food. This is a very interesting, this is a phenomenon that came from parents after we actually asked them about the GI system and the things that they were concerned about. And this is one of the things that really didn't get a lot of press ever. And we realized it was probably due to, again, cranial nerve dysfunction. But what's interesting, it can happen at all ages. So it cannot be there in infancy, in childhood, in developing into, then you hit adolescent, or you hit adulthood, and it seems to be whether those nerves have deteriorated a bit, or whether there's laxity or something's happening, or whether it's just behaviors again that pop up. We all have behaviors that we tend to do more when we're younger or when we're older, and so actually that overstuffing and not swallowing or keeping food there seems to be a problem. It can be a problem with dentition, for the dentist, for dental problems, but it can also be a big problem regarding aspiration, choking. So I had, there was a little girl that was brought to my attention, not where I live, but in a different part of the States, who had aspirated on broccoli that had been kept in hard pieces of broccoli that had been kept in her mouth, and that takes a while to dissolve or to soften up. And she'd actually sort of had it there. They thought she'd finished eating. She'd gone out of the cafeteria, and then she ended up having a choking episode. And 911 was called, and she ended up in hospital with that. So again, I draw you, I'm very, very keen on things that need to be out there, need to be in the literature, and I'm hoping this is a great format for sharing that information. And again, that paper's on my website. Choking is always a worry for parents. It's textures, problems with just general feeding. It can be one of the highlighted real risks for parents to be considering is the choking problems. We often get people working with us like OT and speech language pathologists. As a physician, you mustn't forget what's called vascular rings. We'll probably pop a diagram of that up. So that's where at the end of the esophagus, it's very near to where the heart is. So you've got the heart at the front, and then you've got the gut stuff coming down more behind. There can be a ring from the heart around the esophagus, and it's called a vascular ring. Those can be missed. They're not super common in charge, but they're not completely rare either. So it's something to be thought about. And again, it was brought to my attention at a conference where one mum said that once we got that sorted out, and that was divided, and it was a ring that shouldn't have been there of vascular tissue coming off the aorta, then she said it was actually marvelous because her child, things didn't get stuck anymore, and there wasn't the pain, and there wasn't the problems with the reflux that she'd had before. So it certainly is not the be all and end all, but it needs to be looked at. A big shout out to the cranial nerve dysfunction. I've done a whole talk on this, but the trigeminal nerve, which is your fifth cranial nerve, which affects your sensory to 3 parts of the face, trigeminal meaning 3, and also sensory inside as well, so inside the mouth. So we've got a lot going on with the trigeminal, and we test it by its motor. It's actually motor and sensory, and it's that clenching of the jaw. So we know that which is muscles of mastication, so that clenching down of the jaw is not working with your trigeminal nerve. And again, there's a spectrum of that. So you've got sensory problems there, you've got motor problems, which is the muscle problem, and that can lead to problems with chewing, problems with swallowing, and then you put the facial nerve that's going along in there, being abnormal with your facial palsy, and then you've got a bit of the other cranial nerves, the glossopharyngeal vagus. All of those being abnormal or causing problems can really result in problems with the swallowing. So and that's where the pocketing comes in, and that's where dysmotility, even of when you start, you've got motility down your esophagus, so that's the start of swallowing and motility, and if you've got that's not working, no wonder you end up with reflux. The reflux is I will move on to that in a minute, is very interested in charge. I no longer call it charge reflux. It's reflux that's very specific to charge. So if we move on to that, which is the sort of the first sort of part that in some ways gastroenterologists or pediatricians get involved in, my child's refluxing or seems to be refluxing, is spitting up or is not able to swallow. So very, very common, but I call it charge reflux because it's more a motility problem. It's not really, well, it's probably a bit of everything, but motility has to play a part in that actually. And it's that smaller stomach, the esophageal tube itself probably not functioning properly. Again, I'm surmising this because we know the vagus nerve is affected. But again, we need a lot more research that's going to actually help us with this, and maybe then help in finding the ways to prevent it and to cure it. Reflux is mainly medical management. We have a lot of kids that go under a Nissen's fundoplication. Those often don't work. They need repeating. They can help a bit, but at the end of the day, it's often the medical treatment that's good. We used to use a drug called cisapride, which is a motility drug. That worked very well. Domperidone is a sort of another drug that we use. These drugs, they have different names in different countries, but anything to do with motility is probably good to use We use things like proton pump inhibitors, things that reduce acid, but that's really not coming, that's not getting to the grip of what's really happened, which is a motility problem.